So yeah, so
Gotcha.
let me introduce the first speaker. That's Sarah Dumas. She is an epidemiologist in the Bureau of Epidemiology Services at the New York City Department of Health and Mental Hygiene. She is the project manager for the Health Opinion Poll, an online survey that measures New Yorkers' knowledge, awareness, and opinions about health, healthcare, and health-related programs and policies. She also oversees Health in New York City, a new probability-based panel of New York City adults that has been used to facilitate rapid survey data collection to inform the agency's response to the COVID-19 pandemic. Sarah, the floor is yours.
Great, thank you so much, Ari. Let me see if I can properly pull up my slides here. All right, how does that look? You guys can see my slides? Okay.
Looking good, yes.
Great, thank you so much. I want to talk to you today about the design and implementation of Healthy NYC, which is our probability-based survey panel developed in the Department of Health in New York City. Before I begin, I want to thank my co-authors, especially Sharon Perlman, who is my co-PI on this project. And I want to start by giving you a bit of background about our mission at the New York City Department of Health. In the Division of Epidemiology, our mission is to improve the health of all New Yorkers through population health surveillance and research, public health workforce development, and vital records services. And a really important component of the population health surveillance are the surveys that we do in different populations with different modes and covering different topics. And two that I want to point out to you today are the Community Health Survey, or CHS, which is our flagship survey of about 10,000 adults conducted annually since 2003 about health, healthcare, and health behaviors, and NYC Kids, which is a biennial survey about the health of children 13 and under. So why, in addition to all those surveys, did we want to add a survey panel? This is a very familiar chart to all of you with decreasing telephone response rates across the country in Pew and green, and also here in New York City for our CHS in blue. And this, along with the shift to cell phones, has led to increased cost of telephone data and also led to longer field times, which decreases the timeliness of these data. We've previously used non-probability online panels, which Ari mentioned earlier, to implement our health opinion poll. But as he mentioned, there are some data quality concerns, as well as some concerns about our ability to make generalized inferences about the New York City population with this methodology. And many of the probability panels that you all run didn't have sufficient sample sizes in New York City to meet our needs, or were developed to be nationally representative. So they're not necessarily representative of our unique New York City population. And so a custom probability-based panel offered us a methodological alternative for rapidly and cost-efficiently collecting survey data. And by doing the work in-house, we're able to take advantage of health department's expertise and have more control and flexibility in our surveys, allowing us to respond to emerging public health concerns. So when I spoke here last year, we were in the early stages of planning our panel, including selecting software and developing sampling strategies. And unfortunately, just 1 to 2 days after I returned from that conference, New York City identified its first case of COVID-19 on February 29th, and the situation, as you know, quickly escalated in the city. At the peak of our spring wave, we saw over 1,600 people being hospitalized every day, and as many as 813 deaths in a single day on April 7th. This pandemic quickly highlighted the multiple overlapping public health concerns of health inequities resulting from systemic racism, social and economic instability, and mental health in our city. And these public health concerns urgently demanded new data to inform the city's response. These are just some of the data needs that we identified early on. And while we were able to collect some of these data by flexing our existing surveys, it became clear that we urgently needed to launch our new panel ahead of schedule to collect the data we needed to understand this pandemic and how New Yorkers were experiencing it. And so my aim today is simply to describe the process of designing and implementing Healthy NYC, which is what we named our new probability-based panel, and briefly compare our active panel to the target population of New York City adults across key demographic characteristics. So recruitment and registration to the panel was conducted in 2 phases in June and September of 2020, and we recruited from 4 sources. First, we added a question to the end of 3 probability-based surveys operated by the Bureau of Epidemiology Services starting in 2019. These were the 2019 CHS, the 2019 Kids Survey, and the 2020 CHS. These are the surveys I mentioned to you earlier. The question asked respondents if they would consent to be recontacted for future research, and respondents who agreed on the 2019 CHS or Kids were recruited in our June Healthy NYC wave while those who responded in 2020 CHS were recruited in September. And then we supplemented these records with 2 non-overlapping ABS samples of 30,000 addresses each, one from each of our recruitment waves. And this schematic really just shows the flow of recruitment into Healthy NYC across those 2 ways that I just described. So we have on the left-hand side our June recruitment, and on the right-hand side the September recruitment. From the NYC adult population, we had a random sample of adults in 2 ABS samples and in the 2019 kids response. Sorry, not a random sample of adults, a random sample of households. So in fact, the kids survey is about a random child in the household. So the respondent is not a random adult, but rather a person most familiar with the health of that child. So for those households from 2019 kids and of course, from the ABS, they had to undergo intra-household randomization. In contrast, the CHS respondents were already randomized at the household level when they were selected for CHS. So here, if they provided us with an email or a phone number that we could text, we were able to recruit them directly into Healthy NYC without further randomization. So from these sources, this formed our initial pool of potential panelists, and those who responded to our June, September, or September registration surveys formed our active Healthy NYC panel. Invitations were sent by email or text message, again, only for CHS respondents who had already been randomized at the household level, as well as by mail. Mailed invitations included instructions for inter-household randomization using the next birthday method. There was up to 5 contacts per person, and information was provided in English, Spanish, Simplified Traditional Chinese, and Russian. To join the panel, respondents first had to confirm eligibility and complete a registration survey with basic sociodemographic characteristics. This is a web-first survey, but in our final contact, non-responders were provided with a non-internet option, either phone, a call-in phone option, or mail, depending on the wave. And this allowed us to accommodate New Yorkers who were unable to use the internet, didn't have access to it, or were uncomfortable using it. Respondents received a $20 post-completion incentive by mail or email, and all materials and protocols were reviewed and approved by our IRB. So I just want to show you what our invitation materials look like. You can see the email comes from Health, I hope you can see that, comes from Healthy NYC, and it's branded with the Health Department logo and colors. It's also signed by the Commissioner of Health. The email itself is only in English, but at the bottom we did have a 2-sentence translation in each of the 4 languages, the non-English 4 languages, with links to both the survey and to our homepage where they could find a full translation of the email, as well as additional information about the survey in their language. You can see these emails provide a unique link to the survey. So once they landed on the survey landing page, there was no need for them to enter any sort of ID. And this is what our text messages look like. Similarly, this is a unique URL, and it is a shortened URL. For our push-to-web mail invitations, because we're a government agency, we are limited what we could do in terms of branding and design. So for instance, we had hoped to create our own custom Healthy NYC logo, and we weren't able to do that, but we do think it turned out quite clear and professional looking. You can see the envelope is a simple windowed envelope from the New York City Health Department. The letter includes a brief description of the study, instructions for inter-household randomization, how to access the survey, and information about the incentive and how to learn more about the survey online or by phone. And it is, again, signed by the Commissioner of Health. They could access the survey through, in this initial email, either through a short URL, it's a tiny URL, or through the QR code provided. We later improved upon this by customizing that front end of that URL and also providing a text-in option so that people could receive a link to the survey on their smartphone. The back of the letter has a full translation in Spanish and traditional Chinese, and then there's just a single sentence that provides instructions for how to access a translation of the letter in Russian or simplified Chinese online. In addition to this letter, the packet included an invitation, in the invitation included a 2-page FAQ in English with instructions for how to access translations online. All right, and then going forward, as I compare to the panelists to the New York City population, we performed 1 proportion z-tests and compared to the 2018 5-year ACS estimates. So who actually enrolled in Healthy NYC? So in June, we invited just under 37,000 people, 4,002 responded by web and 472 by phone. And in September, we invited just over 33,000, 3,551 responded by web and 1,290 responded by paper. So you can see in September, we had Fewer web respondents, but a greater proportion of non-web respondents because of the paper option.
I already have a minute, roughly.
Okay. So I think I'm going to go a little into my Q&A time here. I'll skip over this and just point out some of our results here. Young adults and males were underrepresented in the healthy NYC population compared to the New York City population. They made up just, young people 18 to 24 made up just 5% of our panel compared to 11% in the city. And non-Latino white adults were overrepresented in the panel. They made up 46% compared to 34% in the city, while Latino and non-Latino Blacks were underrepresented. Healthy NYC panels were much more likely to have a college degree or higher compared to the adult New York City population, and much less likely to have less than a high school education or just a high school degree. They were also more likely to be US born or speak only English at home. And finally, residents of Manhattan were overrepresented in our panel. They made up 30% of panelists compared to just 21% in our population, while residents of Brooklyn, the Bronx, and Queens were slightly underrepresented. All right, sorry to rush through those, but to conclude, we effectively recruited and registered over 9,315 New York City adults to participate in Healthy NYC. And despite probability-based recruitment methods, we did have differential response resulting in demographic differences between the panel and the target population. This will inform our weighting to mitigate bias in subsequent survey estimates, and may also be used to inform more targeted recruitment in the future. Currently, monthly Healthy NYC surveys are being conducted to estimate the incidence of COVID-like illness and mental health impacts of the pandemic, as well as to recruit for a serosurvey and focus groups, and to assess vaccine hesitancy and mask adherence, among other things. And post-pandemic, Healthy NYC will serve as an ongoing agency resource to meet population-based research and surveillance needs. So I hope I have time for some questions, but if not, I also welcome any questions by email.
No, I think we have some time, so we can, maybe a little less than 5 minutes, but let's spend some time here. So I'm going to read one question I saw that came in on the chat. Paul Ravakis is asking, to earn the $20 contingent incentive, one had to register. What exactly did registering mean? So that's
sorry, I think I missed the beginning of that question. Could you repeat it again?
So what does registering mean? Because for people to earn, they had to earn the $20 contingent incentive, one had to register.
Yeah, the registration was simply a basic demographic survey for the most part. So we asked things like about what borough they were living in, what zip code they were in, race, ethnicity, sex, gender, identification, languages. And the completion of that survey was what actually enrolled them. So another word might be enrollment or empanelment survey.
Okay. So another question is, you mentioned that you gave respondents instructions for within household selection. Do you have a sense of how well that worked?
No, and we did, and I sort of regret that we didn't actually build a lot of survey methodology into the survey. So I would have liked to add either a check or do a household level roster so that we could see if they properly randomize themselves at the household level. And we're actually planning another enrollment in May, and I think that's something that we might add. Either a question just verifying that they check a box and say, yes, I'm the person with the next birthday, or a complete roster that would allow us to check.
Right, okay. So another question is about how successful you think you were in recruiting non-English speakers? Mm-hmm.
Yeah, I think so. I skipped that slide. One thing I did, we had most of our respondents in English, about 300 in Spanish, 150 in one of the Chinese. The Russian language was just 19, and I didn't compare that to the New York City to see what we would have expected. That's something that's pending. I think we probably underperformed in terms of recruiting Russian speakers, and probably that was because we had so few, just one single sentence there in Russian, as opposed to being able to have the entire letter in Russian. But that analysis will be forthcoming.
Okay. So another question is whether you know the percentage that utilize the QR code versus the short URL?
We do. I didn't collect that before this talk. It certainly is being used, but I don't have a percentage for you. But we do have those data available from the QR code provider.
Okay. So these are all the questions I saw in the chat. So, but I think we have 1 or 2 minutes extra. So if anyone else wants to jump in and ask a question, then Oh, there's another question here about the overall response rate taking into account each stage.
Yeah, we're working on that. It's actually quite complicated, as you might imagine, because we
Yeah.
have taken into account the response rates from CHS and from kids as well as the ABS. So it's a complex thing. It's almost done. We are still getting bounce back or returned mail from June, which is crazy.
Right.
So we're trying to, but at some point I'm just going to cut that off, and I think we're going to finalize those this week.
Okay, thanks. So anyone else wants to jump in now? Otherwise, we'll have a bit of time for the general discussion later on. So, well, thanks, Sarah. This is great. So we'll have more discussion later.
Thank you so much.